Usually, right? The productive age males are usually who gets affected, right? Right? So they are lifelong problems, limb-threatening more than life-threatening, right? Okay, right? They are not as obvious as the ischemic heart disease or cerebrovascular disease, but these things, all right, also exist in a fair number. Right? So prevention is more important, and adequate treatment is very important to prevent limb loss. Okay? Because a lost limb in a developing country means a huge burden to the society. Right? Okay. Right? So we have to find out the risk factors for peripheral vascular disease, clinical presentations, relevant investigations, and management options. Right? And of course a little bit about the artery also, that is short, right? Now, second MBBS days, right? The anatomy, right? We taught you dissected the lower limbs, especially upper limbs also get affected by PVD, but we have dissected the lower limbs. You have seen the main thing about the arterial structure from the aorta, how the aorta bifurcates, right? Internal, external iliacs, and from where does it become the common femoral, superficial femoral, profunda femoris, down to the knee joint, the trifurcation, right? The vessels of the trifurcation, where in which compartments they lie. These are important, right? Okay, right down to the pedal pulses, right? Okay, because one of the common things at the short case examination is, you give a patient with retinal limb or something, and you ask, check for the lower limb pulses, right? An examiner might ask, well, where do you check for the dorsalis pedis pulse, right? What is the anatomical landmark? So you cannot forget this anatomy, right? Okay, very, very important, right? Okay, right? Never forget this, right? This is important for your final year exam, right? Okay, yes. Basically, so therefore you have to recall the anatomy of the arteries, especially the lower limb artery, right? Okay, physiology, a little bit function of the arteries, and then the pathology, very important, right? Effects of ischemia, right? Arterial occlusion, the atheromatous plaque. You have learned about the plaque, this is the cap and the whole thing, right? The center, how the plaque ruptures, how the bleeding occurs, how does chronic thing becomes acute on chronic problem. Now I'm not going to go into detail. Pathology has done this, I know, maybe a couple of years ago, right? But you cannot forget that, right? Okay, right. And the risk factors, atherosclerosis, because these are essentially, because atherosclerosis is the most key thing, right, which predisposes to peripheral vascular disease, right? Okay, yeah. So basically, it is not very important, but you must understand which tissues are more resilient to ischemia. Bone is very resilient. Muscle is very, cannot withstand ischemia. That's why myocardial infarctions happen. Just cut out of the respiration to the heart muscle, within a very short time, the muscle becomes dead, right? That's why revascularization procedures of the lower limbs, right? When there's acute arterial occlusion, this is not chronic, acute arterial occlusion, within 6 hours, generally, you have to establish the circulation. Otherwise, the muscles die, right? So you have to know that, right? Now, but we are talking about chronic limb ischemia, that is chronic occlusion of an arterial supply to a group of muscles, right? Due to atheromatous plaque formation, right? What happens? The lumen becomes narrower and narrower, right, due to plaque formation, and then calcification happens, flow becomes further reduced, right? Okay, and when it comes to critical, hello? Yeah. So when it comes to a kind of a critical level, right, what happens is the supply is enough to sustain the muscle at rest, Okay, remember the lumen is, let's say, about 70% narrow of the femoral artery. Now the trickle of blood is enough to sustain the viability of the muscles at rest. But when you exercise, what happens? The demand becomes more, oxygen demand. You need more hemoglobin, right? So and then what happens? You get ischemia of the muscle, transient ischemia, that causes pain. It's the same phenomenon that happens in the heart, very easy, right? Okay, in heart also, that is how you get angina, right? Stable angina, right? Right? So basically, yeah, and beyond that, we call it the critical level. See, this is what I tried to say. See, when you have a plaque development like that, this is the common femoral artery, that's the profound femoral artery, right? Now, see how the common femoral or the superficial femoral artery is narrow, right? So the luminal size is very small, right? At this level, the amount of blood may be sufficient to just sustain the limb at rest, right? When this becomes more narrower, even at rest, the muscle pain will start to come up, right? So that's called rest pain, right? Okay, right. Right. So when you are given a patient, especially in the long case, right? This is something, you know, peripheral vascular disease is a long case, right? It's a PVD patient. Always you get that patient for the long case, right? So when you take the history, these are the things that you have to think of. When the patient gives a history of intermittent claudication, right? You have to differentiate between osteoarthritis, that is pain, difficulty in walking due to joint pain, musculoskeletal problems, stress fractures, neurogenic claudication, now that is very important, right? Okay, that's something that can coexist sometimes with these patients, right? When you have canal stenosis in the spine, right? And sometimes DVT, post DVT legs, right? What's called those post DVT legs after deep vein thrombosis, right? Those patients also develop venous claudication, right? Which is different to arterial claudication. So you need to exclude all these things, like we will discuss in detail when you do your long cases, right? About how to take these histories. But these are important things. You must exclude all these other causes of claudicating or apparent claudicating type pain, right? For you to get defined that the patient is having real arterial claudication. So what is the feature of arterial claudication? Say somebody has a traumatic plaque and somebody says that this patient has claudicating pain. What is the feature of arterial claudication? How do you say that this particular patient has arterial claudication? Yeah. Give me some features of arterial claudication. Yeah, okay, sorry. But neurogenic claudication also sometimes can happen. When the patient starts walking, he gets pain. Where does the pain come? What is the sign?
Cough.
Always cough. Now I told you, sit down, right? I told you this is usually due to ischemia to the muscle. So the pain is in the muscle, right? It's muscle groups, right? So if it is below knee occlusion, yes, it will be in the calf, right? It's at the femoral level, right? So profound femoris is occluded, right? It will be the thigh, right? If your vessels are occluded, getting occluded at aortic bifurcation level, where will be the pain? Huh? Buttock. There are a lot of muscles in the buttock, isn't it? Buttock claudication, right? You don't get what I'm trying to say. So, vascular, you get this thing into your head, right? Okay. Vascular occlusive pain or intermittent, the so-called chronic ischemic pain happens in the muscle group. So therefore in the history, right, you ask for this. Do you have pain in this muscle group, this muscle group, muscle group? It cannot be in the joints. You understand? That's how you differentiate between osteoarthritis and this, right? Okay. In the neurogenic claudication, it's not essentially in the muscles, right? You know, it occurs on a particular dermatome, right? Okay. So it's a dermatome, right? So that's how we differentiate this is that and this. Do you understand what I'm trying to say? Right. Okay. Right. Right. And then usually in intermittent claudication, why do you call it intermittent? The pain comes on, it's ischemic type pain, constricting type pain in a muscle group brought about by exertion, right? Okay, I told you about this supply versus demand thing, right? And usually this amount of exertion that has to be put in to develop the pain is constant. The patients very clearly say, if I walk from here to that gate, that distance, I get the pain. You understand? Right. Which is not like that in neurogenic claudication. It's not a fixed distance, right? So those are the ways that you. This was a essay question in one of your papers, and you know it has asked how do you differentiate between neurogenic and vascular claudication. One of the steps, right? Okay, right. So very important, right? Okay, right. Then what does the patients do to relieve the pain? Huh? Just rest. Okay, if you just stand and wait, that's enough, right? You don't have to do any other maneuvers to relieve the pain. Patients know, just if you just wait, you know, that's enough to relieve the pain. Now when the pain is relieved, once again the patient can walk. But when you walk for a similar distance, the pain comes back, right? Okay, so it's usually a given distance, right? Okay, by exertion. If the patient climbs uphill or starts climbing a step of stairs, then the pain will come earlier than that. So depends on the degree of exertion in a muscle group, right? Ischemic type or constricting type pain. Okay, so that is the typical arterial claudicating pain. You understand? Okay. What are the risk factors, right? So these are other things that you are going to elicit in the history, right? Hyperlipidemia, very important. So in general examination, you are supposed to look at this, all this, dosantheresma, xanthomata, arcus, lipidus, and all these things. Smoking, very important, right? Okay, smoking is the single most detrimental risk factor for atherosclerotic vascular disease. Peripheral vascular disease, when you take the patient, more than 50% of them are smokers, right? Okay, hypertension, you know, and diabetes, right? All these things go hand in hand, right? Okay. Then, how does these patients present? Sometimes asymptomatic, diagnosed during a screening process, right? That is, if you do a duplex scan, you diagnose that there's plaque formation, right? But the patient is essentially asymptomatic, right? Classic claudication, what I have just described to you, right? So that is the kind of patient that you will most probably get at an exam, right? A patient with classic claudication. Then atypical leg pain, odd type leg pain, right? In a particular area, still can be vascular, right? But you have to exclude the other things, right? Okay. The other last section is critical limb ischemia. That is, what is critical limb ischemia? What is critical limb ischemia? That is called critical limb. Right. Okay. What is critical limb ischemia? Critical problem is critical, right? Huh? Yeah, the patient might sustain limb loss if something is not done. Yes, you are right to that, right? So, what do you mean by that? There's impending tissue loss due to profound ischemia, right? Okay, and generally a critical limb ischemic patient has what do you call? What kind of pain? And they could be accessory channel where we assume that you know this something. Because of the breast pain? Huh? No? No. doctor just, hey, okay, right, okay, right? So, typical in this ischemia, right? That is pain just at rest, right? Okay, severe pain, usually in the nights, right? And these people, right, are at the verge of getting the complete vasculature cut off, right? Right? So, I told you about this, right? See, depending on the place of occlusion, right? Okay? We told about this, isn't it? Right? Okay? You can think that is something that you are supposed to elicit, right? In your history. In the people with buttock claudication, what is the other thing that you have to ask? How do I let you? Hey, you people have done a surgical appointment? Huh? Huh? How many? One. One. Sama lump. Very nice. Right. Then excuse. Right. Yeah. So common iliac, right? Internal and external iliac, right? Okay. At the higher level, right? External iliac usually gives branches to the buttocks, right? So buttock claudication. If it is occludes at the bifurcation level, right? You have problems with the internal iliac also, right? Internal iliac supplies the perineum and there are branches supplied in the genitalia, right? Okay. So in a male with buttock claudication, you must always have there's erectile impotence, right? Because that can coexist. You understand, right? That is called lyric syndrome, right? There's a specific name. Buttock claudication with impotence, right? Means that the patient has very high disease, bifurcation disease. All right. Right. So examination findings. Yes, when you are given a patient, then these are things that you examine for. Whether the patient is pale, right? Then system. When you look at other systems, you must see whether the patient is hypertensive, whether he has heart failure, lung function, renal bruise, carotid bruise, because bruise and frills of all the peripheral pulses are very important. Because atherosclerotic disease doesn't only affect the legs, right? Okay. So you have to really look at the other things, right? You have to know how to draw a pulse chart, right? Okay, and lower limb examination in detail, including ulcers, right? So this is called a pulse chart, right? Okay, the femoral pulses, popliteal, dorsalis, pedis, posterior tibial, right? Okay, whether they are present or absent, right? You have to mark like that. Similarly, upper limb pulses and carotid pulses. You understand? You need to be able to draw this little cartoon, all right? Okay, what do you mean by ABPI or ankle brachial pressure index? You'll be doing this for your practical something, right? Right? If you using a Doppler, handheld Doppler and a blood pressure pump, if you take somebody's brachial pressure and in the similar manner you take somebody's ankle pressure, right? Okay. What is higher usually? Ankle pressure is slightly high. Okay, so ankle brachial pressure index, right, is more than 1 or 1 in a normal individual. Either it's equal or ankle pressure is slightly high. Okay. So when it is less than 0.7, various books give various figures, but it is less than 0.7. That means when the ankle pressure has to be low, right? Then you call that the patient is probably having peripheral vascular disease, right? Okay, when it is less than 0.5, right? It's significant ischemia, right? When it's something like 0.2, it's critical, right? Okay, so ankle brachial pressure index is one thing that you can do to check generally what is the status of the ischemia, right? Remember, it is not a reliable indicator in a diabetic. In diabetics, what happens is, apart from atherosclerosis, there's calcification of the vessel, right? Therefore, occlusive pressures by the cup of the lower limbs can be falsely high, right? Although the vessel is occluded from within, but the wall is also thicker, right? Therefore, the ABPI can be erroneously high in a diabetic patient with peripheral vascular disease. Therefore, ABPI is not a reliable indicator in diagnosing peripheral vascular disease in a diabetic. Okay, MCQ. Right. So, look at this, right? So, it's a fair-skinned person. Can you see this leg, right? Erythema, this kind of dusky appearance, shiny skin, right? Okay, right? This is a patient who has had what do you call intermittent claudication, now developing rest pain. You see the vessels are getting occluded. So these are signs of early ischemia. Right? This is how you check ankle brachial pressure index. This is what I have told you about the ABPI. Right? This is how you check the ABPI. Right? See, this is a handheld droplet. Blood pressure comes applied there. Right? You insufflate and you hear from the, because in the leg you cannot use a stethoscope to check pressure. Right? And you, with the Doppler signal only, you get the cup releasing pressure here, which is the systolic pressure at the ankle level, right? Yeah, so how do you investigate the patient? So that's how you examine, right? Then how do you investigate it, right? You do the general examinations, investigations first, ECGs, chest X-ray, for blood count, to see when the patient is anemic, right? Blood sugar, lipid profile, renal function test, because you see the patients can have what you call atheromatous plaques in the renal arteries, and they can be having chronic renal failure, and so on and so forth, right? Okay. Then specific investigations to diagnose the vascular occlusion, right? So the gold standard investigation is a duplex scan, right? And of course specific investigations are angiogram. Right? Okay. So first and foremost, what is a duplex scan? It's a specific ultrasound scan, right? Okay, which has color flow metric. Right? So you can do an ultrasound scan of the vessels, right? And it will show the flows also, right? Forward flow in red, backward flow in blue, right? So you can measure the flow velocity. You can look at the structure of the artery, right? How much the artery has become narrower, the plaques, right? And so on and so forth can be seen by duplex scan. So with the duplex scan, with the flow velocity drops, right? Okay, you can diagnose that where probably the occlusion is, right? So duplex scan is good enough to diagnose the site of occlusion. So in your radiology appointments, please go and see how they do duplex scans of limbs, right? Okay, right? Angiograms. So this is a conventional or a standard angiogram, right? Okay, that's where you inject dye into the arterial tree, right? And take pictures, okay, to see the narrowings of the vessels, right? So this is a lower limb angiogram. Generally, these catheters are passed into the aorta. You start injecting from the aorta. Generally, lower limb angiograms are done by brachial punctures, right? Brachial or carotid punctures, right? You never puncture the femoral artery directly, because if there are plaques there, you will rupture the plaques and the patient will have a huge problem by you trying to do angiogram, right? Direct angiogram, right? So generally, these are catheter-driven angiograms, and these are also called digital subtraction angiogram. Why do you call it a digital subtraction angiogram? I'll tell you why. Because you see what happens is, of course, the aorta part we haven't taken now. Up there is the aorta, right? You position the catheter in the aortic bifurcation and you inject dye, right? What is the flow rate of blood to the lower limbs? Very fast, right? Okay. moment you inject dye, the entire leg gets colored and it gets washed out also immediately, right? So this is usually done with the help of computer, right? It slows down the image, right, and takes this picture, right? Okay. Now, when you do that, what happens, right? Generally, right, it's a white color picture that you get, right? The contrast is white. You have seen contrast, isn't it? Radiologic contrast, you see it's like white, right? Which gets overlapped with the whiteness of the bone, right? Then what happens? Then you cannot interpret properly. So digitally, you subtract the bone density. That's what you do. So you subtract the bone density, and the moment you do that, the colors reverse, right? So can you see just the outline of the bone here? See, little bit, right? The tibia. This one is the femur. You can see just the plate, right? And the bone margin is slightly seen, but the bone density is taken out. And that way, only that you can see the vessels. See that this is the trifurcation at the knee joint level, right? Anterior tibial, posterior tibial. Can you see the sites of occlusion? See, right? And from here, the vessel is completely absent, the posterior tibial artery, right? And then there are a lot of other collaterals. These are called collateral formations. When there is chronic limb ischemia, right? What happens is when the main arteries get occluded, the tiny collaterals expand to supply flow. And sometimes this collateral formation is so good that without the main arteries, the limb will survive. And that is, I won't tell that to you because that's an important therapeutic principle also. We'll talk about that later, right? And this is a film of a magnetic resonance angiogram, MR angiogram. So these are direct digital subsection angiograms. CT angiograms are much more, better, right? But the ideal is an MR angiogram. With the soft tissues, also you can see the very detailed angiogram. And the advantage is magnetic resonance is there is no radiation, isn't it? Right? Okay. Right? See, CT angiogram reconstructed to show the entire arterial tree, right? And this is a digital subsection angiogram. Can you see below trifurcation? Nothing, right? Okay, right? The foot angiograms, right? Okay, can you see the areas of narrowing? Okay, in the dorsalis filippi, the dorsalis filippi are, can you see, right? Okay, so you can take detailed analysis. And this is just a standard digital subsection angiogram. Right, so now you know the general investigation and the specific investigations. You have done a duplex scan, you have done angiograms and found out the areas of occlusion. What are you going to do? Manage that, right? So when you manage one of these patients, it depends on of course, the degree of ischemia and any patient you have to do general management. So it's confounding factors. All the factors which will predispose peripheral vascular disease have to be controlled, right? So the control diabetes, if the patient is a smoker, you stop smoking. Find causes for anemia, if the patient is anemic, and correct anemia. Okay, that's also important, right? Then specific ones, right? Exercises. In people who have got below trifurcation disease, right? Like this. I told you, yeah, like this. Say for an example, see, below trifurcation, this below the popliteal fossa, right? Popliteal artery, this is the popliteal artery, right? So below that, right? Say, posterior and antitibial, the main vessels are missing, right? What happens is there is a lot of collateral formation, right? So, various vascular interventions at this level, below the knee, are generally not very successful. If there's good collateral formation, what you do is you do what's called graded exercise, right? Okay, you get these people, then explain to them. They are claudicants. These are not people with critical limb ischemia. They are claudic patients with claudicating, right? You explain to them, okay, you have this vascular occlusion, but if you do some regular exercises, right, which will brought about claudication, right, these vessels, these collaterals will improve. Then that might be enough to sustain the vasculature of the lower limb, right? So what you do is, actually abroad what happens is, and a supervisor also walks with the patient, right? But at least here we can't do that. But whatever, the ideal management is, first and foremost, you treat the patient for any other coexisting problems in the leg which will prevent them from adequately exercising. What I mean by is that if the patient has a painful callosity, you have to solve that out. If the patient has osteoarthritis or other problems that prevents him from walking nicely, you get that sorted. Provide some good footwear, protective footwear, right? And ideally accompanied by a trainer, the patient walks, right? Patient walks until he develops claudication, right? Then the function of the trainer is to get the patient to walk a little bit more, to create ischemia. You understand? What happens is, you must remember, ischemia promotes angiogenesis. The neovascularization, the capillaries start, right, opening up, right? Then you allow the patient to rest, then walk again. So regularly you do this again in a forced manner, right? What happens is, little by little the patient's collaterals will open up and develop, and the patient will be able to walk a further distance. You understand, right? So that's called so those are called supervised graded exercises. Supervised graded exercises, right? Okay. So supervised graded exercises. Then there are certain drugs, right? You can give analgesics. A lot of patients with peripheral vascular disease are on aspirin. Now remember, aspirin, now when it comes to the heart, the medicine people will say it's cardioprotective. It will prevent the patient from getting a ischemic heart attack, right? But in legs, aspirin doesn't have much of a place. Antiplatelet drugs don't have much of a place in peripheral vascular disease, although we put patients on those. There are other drugs, right? Okay, however, which can improve capillary circulation, like pentoxifylline, right? Okay, so there are certain drugs that you can give, especially on somebody that you are trying to develop collaterals, right? Okay, to improve peripheral circulation, right? Then foot care, I told you, it's very important, because usually it's with a wound or some issue, a disaster starts in this period, right? Okay, doing surgery on the legs are not very safe on these people, so you advise them on proper foot care, right? Okay, then of course you must always think that a patient who's having a peripheral vascular disease or chronic limb ischemia, the main problem is the heart and the brain, right? I told you atherosclerotic plaques don't selectively occur only in the lower limb, right? Okay, so assessing those and making sure that the patient doesn't get a heart attack or a stroke is much more important, right? So these are the drugs that you can give. See, pentoxifylline I told you about, right? The other drugs don't have much of that, right? Right? So then when it comes to a particular point where things are very bad, when the patient has critical limb ischemia or a sprain, impending tissue loss, you have to do revascularization processes of the lower, right? Okay. So they can be anatomical or extra anatomical bypass grafts, right? Either they can be prosthetic grafts, or that means artificial, or they can be reverse saphenous grafts, right? You must know that your saphenous vein, it has valves, right? During direction, right? So if you take the vein out and reverse it, you can use it as a conduit to transmit that. So that is the preferred conduit in most of the lower limb bypasses. It's also used in what? Huh? What? Huh? What? Yes, coronary bypasses, very correct. Right? Coronary bypasses also. Right? You take the veins, you know? So that is much better. You see, the natural grafts, right, that is called the reverse venous grafts, have a long 5-year pattern, see, that prosthetic grafts. Once again, NC, right? Okay, right. Or artificial grafts have a higher chance of occlusion. Natural grafts or the venous grafts or arterial grafts, right? Sometimes you harvest the arteries for CABGs. Nowadays they harvest sometimes the ulnar artery or the radial artery also, isn't it? Right? Okay. But for lowering, it's usually veins, right? So various types of bypass grafts, right? Then angioplasty. What is angioplasty? When there's a stricture, just like in the heart, you do the coronary angioplasty. That case, you pass in a little guide wire through the narrow area plaque, a spectacular shaped balloon, and dilate it. You break the plaque and plaster it to the wall, right? Making the lumen wider. That's called angioplasty. So you can do angioplasty, and better still, you can do angioplasty and put a stent, right, to keep the lumen open. So those are called minimally invasive, right? Okay, surgery is you open and do things. This is within the lumen, you do angioplasty. So angioplasty also is done more and more rather than bypasses for peripheral vascular disease. Just like in the heart. Just like in the heart, right? See? So, for an example, this is the femoral artery, this is the popliteal artery. This is a common area of blockage, right? Around the popliteal because of the trifurcation, right? So, you should, if you are doing a reverse saphenous graft, you graft from the common femoral to the one of the below knee arteries, maybe the posterior gland. So this is called a femoropopliteal graft. One of the most common grafts called what we call as the fempop graft, fempop bypass, right? So likewise, these names are given like that. Okay, if somebody has bifurcation disease at the aorta, you do a laparotomy and put a bypass from the aorta, right? Those are called pantaloon grafts. There's two grafts, so the both limbs, right, at the femoral level, right? So that is aortophyleal grafts, right? Okay, so right, so femoropopliteal, right? That is popliteal here. Sometimes the occlusion can be there, somewhere there. So distal. So then, if you take a graft from femoral to the distal part, it's femorodistal, femdistal, right? Sometimes occlusions can happen only in one side femoral artery, other side femoral artery is patent, right? Then from this side femoral artery to this side femoral artery, you can do a bypass. So that's called femorofemoral. Fem crossover. You understand? So, these words are given just on the location. You understand? So they can be natural graft, that is reverse saphenous venous graft, or they can be prosthetic. Right? Prosthetic grafts are of two types, PTLP and bank graft. Right? All the aortic grafts, ones which are connected to the aorta, are prosthetic grafts. Right? Okay? The high flow systems, you cannot go and suture a vein onto it because it will blow. Right? Okay? So this is angioplasty. Can you see the balloon, the sausage-shaped balloon, right? Okay, we don't do angioplasty the proficient here, but we do this a lot. When you come to the proficient appointment, we'll show this in the biliary, right? Okay, when you have cancers in the cholangiocarcinomas, we break the cholangiocarcinoma in the same manner and then similarly, right? Okay, the same type sausage-shaped balloons, right? You break the plaque and put a stent in, right, to keep the lumen patent. Okay, so this is angioplasty. Right? See, that's the occluded segment, right? And you do angioplasty and put in a stent. See, can you see? It opens up. Right? Okay. Oh, it's a surgery, isn't it? Very good. Right? So we have talked about critical limb ischemia. So this is a patient, see, obviously, who has come with critical limb ischemia. See, impending gangrene, blister formation, right? So patient has had rest pain, now has burst into critical limb. This kind of patient, unless you do a emergency bypass or emergency angioplasty, right, usually the result is an amputation. And that is what we are trying to avoid. I don't think that I can do all this, but this is the kind of thing that you will see in most of the patients, right? Patients who have gone to critical ischemia, right? Now having dry gangrene developing in the periphery, right? Right. I'm sorry, guys. I think I have to stop this. You have another lecture? Huh? Tutorial. You have to go to 2 o'clock. Right. Okay. Yeah. That's about it. So it's a